Hey guys, welcome to the ECG Primer number 1. This is the first of the 4 primers, and in this one we will be covering axis deviation and hypertrophy.
Most of the ECGs in the course are my own or those of my colleagues at Trenton or Belleville hospitals. However, a few I have taken from the internet, namely from these two open source websites, Life in the Fast Lane and ECG Learning, both of which are amazing open source ECG educational websites. Let's look at the components of an ECG. The first thing is the P wave. Now, what's happening here is the SA node fires first and depolarizes the atria, first the right and then the left. And those two create essentially two little triangles that, when combined together, create the shape of a P wave. After that, the electricity travels down towards the AV node and travels through the AV node. This is represented by the PR interval. Now, you might think that the majority of the time is spent traveling from the SA node to the AV node, but in fact, the opposite is true. The connection between the two nodes uses the very fast sodium-potassium pumps that can transmit a signal very quickly. However, the AV node, by design, is intended as a brake in a system and relies on a very slow direct diffusion of calcium ions. So virtually the entire PR interval is actually spent traveling slowly through calcium diffusion through the AV node. After the signal passes through the AV node, assuming you have an intact conduction system, we activate our His-Purkinje fibers, which again use the very fast sodium-potassium pumps to transmit the signals, and we have a narrow QRS spike. It is very narrow and it is usually reasonably tall because it happens in a very rapid fashion. On the ECG, on the x-axis is time, so the wider something is, the longer it takes. Because the His-Purkinje system is functioning and is fast, it results in a narrow, tall spike. After that, the system resets itself. This is represented by the ST segment and the T wave. And as you can see, that one is not narrow and tall and spiky. And the reason is because we don't have this fast conducting system that we're using anymore. Repolarization is something that each cell does on its own. And because it's done cell to cell, it takes quite a time for it to occur, and because of that, we end up with this kind of broad, wide, not so tall wave. There are 3 axioms we need to understand in order to interpret ECGs properly. Axiom number 1 is the fact that the leads are designed to create an upright deflection, a positive deflection, if they detect an increase in positive charge going towards them. Again, remember that a His-Purkinje system uses the sodium-potassium pumps, which result in a net increase in positive charge within the cell. So if you have a wave of depolarization going towards a particular lead, that lead will detect a positive upright spike. Now, the repolarization is essentially an increase in negative charge, is dissipation of all that positive charge that was built up. So it has an opposite electrical sign. Because it has the opposite electrical sign, repolarization will create a positive deflection in a lead if it's going away from a particular lead. The practical result of this is that for a functioning His-Purkinje system, you will have a very fast depolarization, much faster than a refractory period of a myocyte, almost instantaneous. And then you will have a slow repolarization cell to cell in exactly the opposite direction. So depolarization from top of the heart towards the bottom, and then repolarization from the bottom upwards. Because both the directions and the signs of those two phenomena are opposite, they will both produce a positive deflections on the ECG. So usually the QRS and the ST segment are what we call concordant, which is to say they point in the same direction. Axiom number 2 has to do with how tall the deflections are going to be. There is really only three things that will increase the height of a deflection. The first one is the simplest one. It's if you do have more muscle mass, you will create bigger deflections, because after all, the deflections are simply a reflection of many cells changing their charge. If you have bigger cells or more cells, you will have more deflections. The second one is proximity. If you have somebody who's very thin, there is less of a distance and less of interposing tissue between the electrode and where the electricity is being generated in the heart. Therefore, for a very thin person, generally all the leads will produce taller deflections, either positive or negative. And then finally, if you have a conduction problem, you will have essentially an increase in the size of the QRS. This has nothing to do with an increase in muscle mass or proximity, but simply a reflection of the fact that it now takes longer to depolarize, which means that the area under the curve of a QRS with a conduction problem is going to be larger than that of the one without. Notably, this will only be visible in the leads that are affected, that are looking essentially in the direction in which this conduction problem is occurring. More on that in a second. Axiom number 3 is that vectors can be broken down into their component parts. Let's say that electricity, like in this picture, is going left and up. Well, that overall vector can be broken down into two component vectors, one which is horizontal and one which is vertical. In this case, the horizontal one will be going leftwards and the vertical one will be pointing up. When you see pictures or diagrams of the heart, it's usually visualized as two sides of the heart lying side by side, oriented diagonally down and in the parallel orientation, but that's not the actual anatomical reality. If you look at the LV on this actual anatomical picture of the heart, you'll see that the LV is in fact oriented like that. So it sits behind the right ventricle and it is oriented diagonally and down, but the RV is not. The RV is sitting in front of the LV and it's oriented much more vertically down. So if we draw a diagram as to the orientation of the two chambers, we will see the RV standing in the front, pointing essentially vertically down, and then behind it we have the LV, which is pointing in the diagonal fashion downwards. So what does that mean? Well, remember that the vectors of depolarization are simply a reflection of where the muscle mass is and how the charge within the muscle mass is changing. So if we look at the LV, which is pointing kind of diagonally leftwards and down, that is going to be the overall vector of depolarization of the LV. And if we look at the RV, we said it's pointing almost vertically downwards. So the overall vector of depolarization is going to be essentially down. Again, remember that we can combine vectors and break them down into component parts. And if we combine these two vectors together, we'll end up in an arrow that's slightly between the two of them, so a slight bit more downwards than where the LV is going. And majority of the deflection is going to be caused by what the LV is doing, by the simple fact that the majority of the muscle mass is sitting on the left. Now it's time to introduce the Eindhoven triangle, which I'm sure you're familiar from medical school. Eindhoven was the first electrophysiologist who connected these electrodes. They give us a view as to where the electricity in the heart is going in two dimensions, in the horizontal and the vertical plane. Just as a reminder, the lead 1 will turn positive if the electricity is going towards the left. It's a purely horizontal lead. It doesn't care what's happening in the vertical plane. Then you have the lead 2, which looks left and down. The other left-looking lead is lead AVL, which looks left and up. and then you have the two downwards looking leads, the AVF, which is a purely vertical lead. It looks straight down. It doesn't care what's happening in the horizontal axis. And then you have lead 3, which looks down and to the right. We also have the lead AVR, which looks up and to the right. That would be a very unusual axis. So most of the time, we don't have to include AVR in our analysis, with some important exceptions, which we will come to later. And remember the picture that we drew before. Where is the overall electricity going, right? We said the LV is pulling it down and towards the left, and then the RV is going to pull it a little bit more downwards than just where the LV is going, but the overall vector of depolarization is going to be down and left, which means that for an average EKGs, the leads that look leftwards in the horizontal plane will be positive, and the leads that look downwards in the vertical plane will be positive. Let's take a look at an example. And I'm going to teach you a method of axis interpretation that's a little bit more fine-grained than what you're used to. Most people do it through simple rules of thumb, like whether the leads 1 and AVF are looking towards or away from each other. But indulge with me, and it will pay huge dividends down the line. First thing we're going to do is we're going to look at lead 1. Remember that lead 1 is a purely horizontal lead. It only cares where the electricity is going in the horizontal plane. So if the electricity is going leftwards, you will have positive deflection. If the electricity is going rightwards, we will get negative deflections. So let's look at this particular lead 1, and we see that it's positive. Majority of deflection is positive, so it means the electricity is going towards the left. Now, let's compare lead 2 to lead AVL. Again, remember, lead 2 looks down and left, and lead AVL looks up and left. So both of those leads will turn positive if the electricity is going leftwards in the horizontal plane, but there will be a difference between them caused by the fact that 2 looks downwards in the vertical plane and AVL looks upwards. In fact, the entire difference between the two will be explained by what's happening in the vertical plane. So let's look at the two of them and just decide which one has more positive deflections. And we'll see very quickly it's lead 2. So right away we know that the electricity is going down and towards the left. Okay? If that is the case, if the electricity is going down and towards the left, we would expect lead AVF to be positive, because AVF is a purely vertical lead that only cares what electricity is doing in the vertical plane, and it turns positive when the electricity is going down, as is the case here. And if we look at the lead AVF, we will notice, in fact, it is positive. Now, lead 3 is a little bit trickier, because lead 3 looks down and the right. And in this particular case, electricity is going down and left. So it's going to like the fact that electricity is going to go down. So we're going to have some positive deflections, but we're also going to have some negative deflections because the electricity is going leftwards, and this lead looks down and right. So let's look at lead 3, and we will see that, in fact, it is mostly positive, but it is less positive than lead AVF, which is to be expected because lead AVF doesn't care about the left versus right, but lead 3 is diminished by the fact that it wants the electricity to go rightwards, and in fact, in this case, the electricity is going towards the left. So this is the overall pattern of axis interpretation we're going to use. We're going to look at lead 1 to tell us where the electricity is going in the horizontal plane. Then we're going to compare lead 2 to AVL to tell us where is it going in the vertical plane. And again, lead 2 will be dominant if electricity is going down, and lead AVL will be dominant if electricity is going up. And then we will use leads AVF and 3 to kind of fine-tune our orientation and figure out exactly where the electricity is going. And again, if we draw an arrow where the electricity is going in this particular case, you will see this diagonal line going down at about 45 degrees, just in the direction of lead 2. Now, let's look at another slightly different example. Let's look at a lead 1. Again, it is mostly positive, but there is a significant negative charge as well. In fact, it is almost isoelectric, which means there is an equal amount of positive and negative charge. What that means is that electricity is going to 90 degrees perpendicular to where a particular lead is looking. Again, lead 1 looks purely horizontally towards the left. So electricity, if it's going perpendicular, could be going almost straight up or almost straight down. We know it's not purely perpendicular because there is in fact a little bit more positive charge than negative, so we know there must be a slight leftwards horizontal components. So it's angled a little bit left and up or a little bit left and down. To answer where it's going in the vertical plane, let's look at leads 2 versus AVL. Lead 2 is strongly positive, lead AVL is mostly negative, which means the electricity is going down and a little bit to the left, which would very much agree with where lead 2 wants you to go. Lead AVL, the slight positive charge, the positive deflection is caused by the horizontal component, by the slight leftwards deflection of where the electricity is going, and the negative charge is caused by the fact that the electricity is going down when AVL wants you to go up. Now let's look at lead AVF. We expect that it's going to be strongly positive because the electricity is going very much in its direction downwards. And then we're going to expect lead 3 to be slightly less positive. Why? Because of that slight leftwards deflection. And again, remember, lead 3 wants you to be looking down and right. Because it's not going to like that horizontal deflection, but it will like the vertically down deflection, it's still going to be overall positive, just less positive than lead AVF. Now, the Eindhoven triangle was designed to give us an idea as to where electricity is going in 2 dimensions, in the horizontal and the vertical plane. Unfortunately, we live in a 3D space, so we have to add the 3rd dimension, the z-axis. So let's again take a look at the picture of the heart. We will see that the RV sits in the front, kind of bulging towards the chest wall, while the LV kind of curves away towards its apex, which is down left and away from the chest wall towards the kind of posterior chest. Right? Now again, remember, most of the muscle mass is on the left, so the overall vector of depolarization is mostly going to follow what the left side of the heart is doing. So most of the hearts, the normal ones, the overall wave of depolarization in 3 dimensions will follow the LV, and it will go down, left, and then away from the chest wall and curving away towards the apex. This is where the precordial leads come in. They were designed to tell us where electricity is going in 3 dimensions, or rather in the 3rd dimension. And how they work is you take the electrical center of the heart, which is the AV node, and then you draw a line from that imaginary point to where the lead is on the surface of the heart. So if you look at this diagram, you will see that lead V1 is going to be positive, or will like if the electricity is going from the AV node right up and towards the sternum, towards the front of the chest wall. Lead V2 will be left, up, and again towards the sternum, towards the chest wall. And then as we go to lead V3, V4, V5, they will slowly curve downwards towards the left and away from the chest wall and towards the apex. Now remember again that the axis of 3D depolarization of an average heart is down, left, and away from the chest wall towards the apex, correct? So that means that majority of the time, the precordial leads, which will have strong positive deflections, are going to be those that look down, left, and towards the apex and away from the chest wall. So those will be leads V4, V5, and V6. And the other leads will be more negative, especially lead V1, which completely looks in the opposite direction of where the electricity is going. So let's look at the precordial leads of this normal ECG. Okay, we will see, as we discussed just before, the lead V1 is completely negative. This is because the electricity in this particular ECG is going in its usual direction, down, left, and away from the chest wall, and lead V1 looks up, right, and towards the sternum, towards the chest wall. Now lead V2 starts to look leftwards, so we see a little bit of positive charge. Lead V3 is a little bit downwards from lead 2 and more to the left, so we see more positive charge, and then more in V4, and then V5 and V6, as those leads are looking more and more towards the apex of the LV, where the majority of the muscle mass is. You can see in this particular ECG, lead V5 is the biggest, which means that the apex is pointing in the direction of V5. Sometimes it's pointing a little bit anteriorly at V4, sometimes it's pointing a little bit posteriorly at V6. Most of the time, it's going to be somewhere between V5 and V6. So this is a normal heart. It starts completely negative in V1, and then we have a progressive buildup of positive charge as we go towards V5 and V6. This is called the R wave progression because the R waves are the positive waves, and it is caused by the leads, or where the leads are looking in the precordium, being more and more aligned with where the average heart's electricity is going in 3 dimensions. Because it's quite complicated adding vectors in 3D, we're going to simplify it into a kind of yes or no question. Basically, we're going to decide in 3D, is this heart right dominant or left dominant? If the RV is dominant, if for whatever reason the RV has become bigger and is now the dominant muscle force, then in 3D, the vector, remember again that the RV sits in front of the LV and bulges towards the chest wall, while which leads are in the front and looking at the surface of the sternum, leads V1 and V2. So those leads will be positive, and then all the other leads will be negative. If, as is normal, the LV is the dominant force because that's where most of the muscle mass is, the leads V4, V5, V6, which look towards the apex of the heart, will be positive, and then leads V1, V2 will be strongly negative. So far we have looked at a heart where electricity is going in the usual direction, which is to say left, down, and away from the chest wall and towards the apex. Now let's look at a heart where the axis is deviated towards the left, which is to say the electricity is going up and left. Well, something must have caused the overall vector of depolarization to shift that way. So let's remember axiom 2, the things that appear or make the mass look bigger on a particular side are proximity, increased muscle mass, and conduction blocks. Proximity is symmetrical. If you're very thin, it wouldn't change the direction in which the electricity is going. It would just make your QRSs taller. So that's not it. So we're left with really 2 causes. Increased muscle mass on the left and conduction blocks. So in the order of frequency, the commonest one is left ventricular hypertrophy. So again, just more muscle mass on the left. Then the left bundle branch block, which is blockage of both of the fascicles on the left side, followed by the left anterior fascicular block, which is blockage of the anterior fascicle on the left side only. Let's work out the vectors for one of these cases. This is a case of fairly classic left ventricular hypertrophy. Let's work out the 2D and the 3D vector of depolarization first. We look at lead 1 and we see that it's strongly positive, so it means the electricity is going leftwards in the horizontal plane. We compare lead 2 to AVL. Which one is bigger? It's AVL, so it means electricity is going leftwards and up. And if that's the case, we would expect AVF to be negative because it wants electricity to go down. And we would expect lead 3 to be more negative because it wants the electricity to go down and right, which is exactly the opposite of where it's actually going. So in 2 dimensions, there is left axis deviation, and the overall vector of depolarization is left and up. If we look at a 3D, in the precordial leads, we see a fairly usual picture of left dominance, which means that V5, V6 are strongly positive, and V1, V2 are strongly negative. So again, it's a left dominant heart in 2D and 3D with some left axis deviation. Now, let's figure it out just from first principles if there is increased muscle mass on the left. So if there is, we would expect the leads that looked leftwards and upwards and towards the apex to become more strongly positive and taller. And those leads would be 1, AVL, V5, and V6, and that's exactly what we see. Conversely, we would expect the rightwards looking leads like V1, V2, and 3 to be strongly negative. And that's exactly what we do see here. So you can memorize the formal criteria, but just understanding what's going on can give you a pretty clear picture of whether hypertrophy is present or not. The formal criteria are as follows. The most specific one is if AVL is more than 11 millimeters, which is more than 2 of the large boxes. Then the second one is if the upright deflections in V5 or V6 are more than 5 square boxes or 25 millimeters, or if the negative deflections in V1 or V2 are more than 5 boxes or 25 millimeters. And finally, if the combination of the upwards deflections in V5 or V6 and downwards deflection in V1 or V2 are more than 7 squares or 35 millimeters. And if you look at carefully, you'll see that actually all of these criteria are fulfilled in this particular EKG. And again, just a recap of the formal LVH rules. The most specific one is AVL more than 11 millimeters, so just bigger than 2 of those boxes. Then the positive deflections in V4 to V6 more than 5 boxes, or the sum of the positive deflections in those leads and the negative deflections in V1 more than 7 boxes together. And then finally, if the positive wave in 1 and the negative wave in lead 3 are more than 5 boxes added together. Who cares about left ventricular hypertrophy? If you're young and fit, it's fairly normal to have this. If you're young and not particularly fit, then it's probably normal, but maybe you do have hypertrophic obstructive cardiomyopathy, although there are usually some other signs on the EKG of that as well. And if you're an older person, usually it's because of chronic high afterload states, chronic hypertension, aortic stenosis, or rarely hypertrophic obstructive cardiomyopathy. Let's now look at a left bundle branch block, which again is blockage of both of the fascicles on the left side. So first of all, let's look at the axis. Again, lead 1 is positive, so it's going leftwards. Lead 2 and AVL are actually of the same size, so it looks like electricity is just going leftwards in the horizontal plane. And if we look at lead AVF, we see that it's isoelectric, so pretty equal positive and negative deflections, which fits with electricity going straight towards the left in the horizontal plane. So no left axis deviation, but a left dominant axis, right? Dominated by the muscle mass of the LV. Similar story in the 3D precordial leads. We see really strong positive deflections in V6, a little bit less in V5, and then strong negative deflections in V1 and V2. So again, a left dominant heart in both 2D and 3D leads. Second thing we should notice is that the QRSs are wide. This is simply because the electricity is taking a very long time to reach all the cells in the ventricle because the His-Purkinje system isn't working, so all the cells have to depolarize and spread the wave of depolarization individually cell to cell. Third, you will notice what's called QRS to ST discordance, which means that when the QRSs are positive, we have ST depressions, and where the QRSs are negative or downwards deflection, we have ST elevations. This does not mean that there is ischemia. This is perfectly normal, and we will explain why in a second. Fourth, you will see, and this is best seen in lead 1 on this particular EKG, you'll see a little notch on the top. Well, that notch is the right ventricle depolarizing quickly with its functioning fascicle in the middle of the slowly depolarizing left ventricle that doesn't have a functioning fascicles. And because the right ventricle is depolarizing in opposite directions to the left one, you'll see the superimposition of the RV on the LV, which will be represented as a little RS R prime pattern. The final thing that identifies the CKG is a left bundle, and this is more of an experiential thing, is that you can see that the QRSs, especially in the precordial leads, are asymmetrical. So look, for example, at lead V2, the R wave, the positive one, begins upwards, and then it goes almost vertically straight down, and then comes back at a bit of an angle towards the ST segment. This is not going to be the case with things like VT, which are more symmetrical. So these are the 5 things that we must have to call something a left bundle branch block. We need to have a wide QRS, a left dominant axis, a QRS to ST discordance where they're pointing in the opposite directions. We need notching or RSR prime in some leads, and then we need asymmetrical negative deflections in precordial leads. Okay, and what's happening again is that both of the fascicles on the left side have been blocked. Again, why do we get the notching that we do in the left bundle, that small notch on top of the QRS that's usually mostly visible in leads 1 and AVL? Well, again, remember that vectors are additive, and what's happening is the fascicles that depolarize the left ventricle have died, so it's taking a long time for the left ventricle to depolarize in the leftwards direction. What's happening while the left ventricle is slowly depolarizing leftwards is the right ventricle very quickly, because it has a functioning fascicle, will depolarize rightwards in the opposite direction. So when you superimpose the small RV depolarizing in an opposite direction of the large but slowly depolarizing LV, you ended up with that little notch. The notch is the RV depolarizing in the opposite direction during the slow prolonged LV repolarization. Now let's explain this QRS to ST discordance, because it's a very important concept that's going to come very handy when we start looking at ischemia. So normally we said the QRSs and the STs point in the same direction, because if we have a functioning conduction system, the depolarization happens very quickly, and then everything slowly repolarizes in the opposite direction. But because both the signs between depolarization and repolarization and the direction are opposite, the result is deflections in the same direction. So if you have a positive QRS, it would be normal to have a positive ST segment. Now, in a left bundle, that relationship has broken down. Because the fascicles have been blocked, it's taking a very long time to reach the bottom of the heart. In fact, longer than the refractory period of the myocytes. So as the bottom of the heart is depolarizing, the top starts to repolarize. So now we have depolarization and repolarization going in the same direction, but they're of the opposite electrical signs. Depolarization is increasing positive charge, repolarization is increasing negative charge. What that means is that electrodes, which are set to go positive when there is more positive charge going towards them, and to go negative when there is negative charge going towards them, are going to show the QRS and the ST segment pointing in the opposite direction, or discordance. So why do we care about the left bundle? First of all, it's quite common. It's more common with old age, and risk factors for coronary artery disease, things like cholesterol, diabetes, hypertension, and smoking. Occasionally, they can happen either because you had a heart attack and you blocked off or killed off all the conducting fibers, or you're in the middle of a heart attack. So in the previous iteration of the American Heart Association guidelines, a new left bundle in the presence of chest pain was considered to be a STEMI equivalent. This has been taken out of the latest iteration because it has in fact been shown that a very small minority, less than 1 in 6, of new bundles, quote unquote, in the presence of chest pain ended up being significant occlusions, and the commonest reason for a new left bundle is simply the fact that somebody hasn't had an EKG for a while. That said, though, the discordance between the QRS and the ST makes it very hard to look at the ST changes acutely, because there is always presence of ST depressions in the upwards looking QRSs and ST elevations in the downwards looking QRSs. Luckily, we have developed a set of criteria that allow us to look at ischemic changes even in the presence of this discordance. The least common reason for left axis deviation would be a left anterior fascicular block. So this is kind of like a half left bundle branch block where only the anterior fascicle has been killed off or blocked off with time. So now the electricity in the left side of the heart gets conducted down the posterior fascicle, which is at the bottom of the left ventricle, and then it spreads from there in the left and upwards direction, cell to cell, in the direction of the non-functioning left fascicle. So basically what it looks like is left axis deviation, so overall 2D axis going left and up in the absence of hypertrophy in the chest leads, and usually there is a little bit of QRS widening as well. Now also in the presence of LVH or left ventricular hypertrophy, it is quite common to end up with a left anterior fascicular block as well, simply because that hypertrophy infiltrates and cuts off the conducting tissue. Who cares about a left anterior fascicular block? We don't care about it much. Like the other conduction blocks, it usually happens for reasons of age, coronary artery disease risk factor, or sometimes because you had a heart attack and you killed off those conducting fibers. The main reason to know about it is that it's a fascicle. So if you have 2 fascicles that have been blocked or 3 fascicles that have been blocked, you might need a pacemaker, especially if you come to, say, emergency department with syncope. So far we have dealt with normal axis and then left axis deviation. Now let's look at a right axis deviation. Just like for left axis deviation, axiom 2 tells us there needs to be either an increase in the mass on the right side of the heart or a conduction problem on the right side of the heart that results in the shift of the vector of depolarization towards the right. Slightly differently than on the left side, the commonest reason for this is a right bundle branch block, then right ventricular hypertrophy, and there is also the extremely rare left posterior fascicular block, and in fact it's so rare we won't cover it here. We'll focus on the first 2 things. So let's just clarify what we mean by right axis deviation. By that we mean anything where the vector of depolarization overall is more than 90 degrees, so more than vertically down. We can see why that is. Remember that our RV stands at the right side of the heart and goes essentially vertically down. Now, if you had an increase in the RV, it's going to start bulging out towards the right side, and that's going to move the overall vector of depolarization, which is usually mostly determined by the LV. But now if we have an increased muscle mass on the right, that's going to start pulling it right and down. Then in the 3D, in the precordial leads, remember again that the RV sits in front of the LV and kind of bulges towards the sternum, towards the chest wall. So we would expect leads V1 and V2, which look towards the front of the chest wall, to be strongly positive. Let's first look at a case of right ventricular hypertrophy because it's easier to explain. So first of all, let's look at a 2-dimensional axis. So lead 1 is negative, so we know that the electricity is going towards right. Now let's compare lead 2 to AVL. It looks like lead 2 has positive deflections and AVL does not, so we know that electricity is going down and right. Now, if that's the case, we expect lead AVF to be somewhat positive because it likes the downwards component, and we expect lead 3 to be strongly positive because it likes that the electricity is going down and right, and that is exactly what we see. And then look at 3D precordial leads. So again, normal would be for V1 and V2 to be negative and V5 and V6 to be positive. What we see here, in fact, is V1, V2, and then V3. So all the leads that are sitting in the front and are looking towards the sternum, towards the front of the chest wall, are very strongly positive because of that big bulging RV. So those are your criteria for RV age. There is no universally accepted formal criteria, but if you see right axis deviation in both 2D and 3D and a narrow QRS, then you're dealing with right ventricular hypertrophy. Now let's look at a case of a right bundle. Now remember again, there is no necessarily an increase in the muscle mass on the right with a right bundle. However, the conduction problem is going to make the right appear more prominent because the overall area under the curve is going to increase because everything is taking longer. The depolarization is taking longer. So if we look here, the best place we can see the right bundle is in leads V1 and V2, which look directly at the RV, right? At the RV that bulges towards the front of the chest wall. So we can again see that V1 and V2 are strongly positive, which is not usually the case. They usually are strongly negative, but also we see a very pronounced RSR prime, so positive, negative, positive deflection in there. What's happening here is just like in the left bundle, it's a superimposition of the two vectors. The negative deflection is the LV depolarizing very, very quickly in the middle of the slowly depolarizing RV, and the LV is depolarizing in the opposite direction, so it produces a negative deflection superimposed on this big, broad, upright QRS produced by the right bundle. And this is pathognomic for the right bundle. Also note that a second peak is higher, and that also is pathognomic for the right bundle. Again, let's explain the morphology of this. We'll focus on V1 because it's more pathognomic. And it's the same principle as with the left bundle. It is a superimposition of the left ventricle quickly depolarizing in the opposite direction of the RV, which is taken a longer time because its fascicle is now non-functioning. So the first upright deflection is actually the septum, which depolarizes in the rightwards direction. Then you have the LV depolarizing quickly in the opposite direction, thus the negative deflection. And again, the negative deflection is much bigger. That bite is much bigger than in the left bundle because the LV is much bigger than the RV is, so it will create a bigger deflection in the opposite direction. And then the final positive peak is from the RV finishing slow depolarization towards the right and the front of the chest wall. Now, who cares if there is a right bundle on the ECG? Well, a lot of them are normal, especially young females can have a right bundle in the absence of any actual problems with their heart. But if you do see it in an elderly person, it's usually caused by chronic pulmonary problems like COPD, pulmonary hypertension, or obstructive sleep apnea, or it can be caused if, for example, you have a recent ECG and there was no signs of a right bundle, and currently they do have it, they might have an acute pulmonary problem like a pulmonary embolus. And finally, people who have had right-sided MIs and who have infarcted portions of their RV might have infarcted the conducting fascicle portion of it and induced a right bundle branch block. So there we go. I know this was a lot of work, and perhaps it's not entirely clear or obvious just yet. Don't worry about it. We will do lots and lots of examples and explanation throughout the course, and I promise everything will be clear before you leave. In the meantime, there is a quick little cheat sheet you can use. Remember, for the left axis deviation, electricity is going strongly left and up. The leads that look in those directions are 1 and AVL, and this should be positive, and then leads that look downwards, like 2, 3, and AVF, should all be negative. So those two sets of leads should be looking away from each other. If you have a right axis deviation, we expect the rightwards looking leads, so specifically 3, but also to some degree AVF, and perhaps even 2 to be positive, while leads 1 and AVL will be negative. So now those two sets of leads will be looking towards each other. So that gives you a quick cheat sheet on the axis. As far as hypertrophy, again, just remember that in the left ventricular hypertrophy, the left-looking leads become taller and upright, and the right-looking leads become taller and negative. And with right ventricular hypertrophy, we have an overall shift of the axis towards the right. As far as the bundle branch blocks go, remember that you need all 5 criteria to diagnose the left bundle, and for the right bundle you will see positive deflections in V1 and V2, and you will see a very prominent RSR prime, with a second peak being the bigger of the two. Alright, this is all for this primer, and we will see you again in primer number 2, bradycardias. Thank you for listening.